Well, good morning, everybody, or good afternoon, I should say. Thank you all for joining us from your offices and your homes and your conference rooms and middle seat of an airplane, wherever you might be right now. Thank you. As you know, you have joined the Grand Rounds presented by the Department of Psychiatry and Behavioral Sciences. My name is Jed Thompson. I'm the host. I'm the Associate Director of Communications for the department. And while we give people time to join, I'll go over a few of the logistics about our grand rounds, and then we'll meet today's wonderful speakers. So, as you logged on, you probably heard that we are recording this session. So it will be available to you next week. If you'd like to find it, we have a Grand Rounds archive on our website, so that will be posted there. We are sponsored by our department, as well as the Ripley Fund and the Garvey Institute for Brain Health Solutions. And if you'd like to provide some feedback following today's presentation, there will be a survey, and that link will appear as soon as the webinar is closed. You'll see a link to our survey, and you can give us your feedback on today's presentation. So I encourage you to do that. Our next presentation will be next Friday, April 4th, and that will be with Dr. Matthew State. So please plan to join us again next week. And before we meet today's speakers, just wanted to let you know we are going to try to leave around 10 minutes or so at the end if you have any questions. So we have the Q&A feature activated, the chat feature is activated. So at any point during this presentation, if you have any questions that pop into your head, go ahead and write those out. I'll have those queued up, and then I will rejoin you all at the end, and we'll go through about 10 minutes of a Q&A session. So with that, we've got two really good speakers here today, and the chair of our department, Dr. Jürgen Unitzer, is going to introduce them to you. So Jürgen, I'm going to toss it over to you now.
All right, thank you, Jed. Good afternoon. Welcome to Psychiatry Grand Rounds, everybody. Today, we have a really special treat for you. I have invited two of my colleagues, Doctors Richard Ellenbogen and Bay Leslie Mosby. Those two gentlemen chair our departments of neurology and neurological surgery here at UW-Medicine, and they co-lead the UW-Medicine Neuroscience Institute. And they're joining us for our grand rounds today. And before I say more about them, I'm going to say a little bit about neuroscience and brain health. So one of the things that we have in common with our colleagues in neurology and neurosurgery is that we're all interested in the brain. That 3-pound organ in our heads that makes up about 2% of our body weight, but it uses 20% of our body's energy. With more than 100 billion neurons, and a whole bunch of trillions of connections, that organ really makes us who we are as humans. And I think that's something we all are fascinated by. And the Institute for Health Metrics and Evaluation tells us that, diseases associated with the brain are the #1 drivers of health-related disability worldwide. So we share an interest in this organ, and I think we focus on different sets of problems that occur when our brains fail us. So in psychiatry, we're thinking about mental illnesses, schizophrenia, bipolar disorder, in autism, and things like that. And actually, next week's grand rounds, Matt State is the chair at UCSF. He's a great speaker, so join for the presentation on autism if you get a chance. And with our colleagues in neurology, we share an interest in neurodegenerative diseases and dementia. And with our colleagues in neurological surgery, we share interests in the behavioral manifestations of things like brain tumors and traumatic brain injuries. And while I think we have somewhat different traditions and we use somewhat different approaches and tools, if I had a crystal ball to make a wild prediction about the future, a future that I probably won't see during my professional lifetime, I would say that somewhere in the future, in 15 or 20 years, we may not have neurology and psychiatry as separate specialties. We may all be working together in a department called brain health or something like that. And wouldn't that be interesting? So But for now, enough of my philosophical musings about the brain. Let me say a few words about our presenters today. Uh, First of all, I want to say that these two gentlemen are truly amazing and inspiring physician leaders and great colleagues. The kind of colleagues that often make me wonder, how did I get here? What am I doing here at UW Medicine? I'll start with a few things about Dr. Ellenbogen. Dr. Richard Ellenbogen chairs our Department of Neurological Surgery. He also co-directs the UW Medicine Neurosciences Institute along with Dr. Leslie Maswi, and he's an amazing doctor. Rich operates and cares for patients across several of our hospitals, all the way across the whole age spectrum. He operates at Children's, he operates at Harborview. He takes care of some incredibly sick patients, and he just shared with us before we got on here that oftentimes when he does a great operation and he feels like he's done a really amazing job, and he has done an amazing job, he has to sort of remind himself that maybe he met that person, that patient and their family on the worst day of their life. So really, really humbling to sort of think about the kind of work that he and his colleagues do. But that's not all. He not only is the chair of the department, he directs the residency program here in neurosurgery, and he's a founding co-director of the Seattle Sports Concussion Program. That's a program that's jointly sponsored by UW Medicine and Seattle Children's. But that's not enough. He chairs the ACGME Residency Review Committee for neurological surgery. He has chaired the American Board of Neurological Surgery. He's been president of the American Society of Pediatric Neurosurgeons, president of the Society of the University Neurological Surgeons, and president of the Congress of Neurological Surgeons. I have no idea how Rich does all of this, but it's got to be one of the most hardworking physicians I've ever met. And in addition to all of that, he's a great colleague. He's a really great neighbor of mine and a really good friend. So welcome to Rich. A few words about Dr. Leslie Maswi. Dr. Leslie Maswi is the chair of our Department of Neurology here at UW Medicine. He's a great colleague. He's a real inspiration to me and to many of us. He will say the kinds of things in a meeting with other department chairs where everybody gets quiet and thinks and listens. And I think that's something that's really, really precious. I think we were really fortunate to recruit him and his spouse here from Harvard a few years ago. He's a really interesting and unique neurologist in that not only did he train in neurology, but he trained in neurological critical care and in interventional neurology and endovascular neurosurgery. So he's one of those guys that, when we have our thrombotic stroke, he will pass a little catheter up into our brain and fish that thing back out, and we'll walk out, something that we couldn't have imagined, even 10 or 20 years ago. So fascinating work that he and his colleagues do. In addition to his work here at UW Medicine, he serves on a number of national committees, editorial boards, and oversight bodies for big randomized multi-center trials in cerebrovascular disease. He's got a real passion for improving care, and I think a great sense of the potential for neuroscience and for improving the care of people living with neurological illnesses. So with all of that, I really appreciate that Doctors Leslie Maswi and Ellenbogen have taken the time to talk with us today. I asked them to give us a little update on what the UW Medicine Neuroscience Institute is about. And so today they will talk with us about Inside the Mind, insights from the UW Medicine Neuroscience Institute. I really look forward to your presentation. Thank you, and welcome to both of you.
Thank you very much, Jürgen. We can finish now. That was pretty humbling, and I appreciate those kind words. And this talk derived from the fact that your chairman, Jurgen, came to the Department of Neurological Surgery and gave an amazing talk, blew us all away to talking about psychiatry and talking about the challenges in psychiatry, finding targets in the brain, and the need for more psychiatrists. And it was fascinating. What I realized is in one of the most collaborative universities I've ever worked in, we need to be doing this more often. So thank you, thank you, thank you, Jurgen, for letting us participate with you, Bay and I. Go ahead.
All right, so I just say we have no disclosures that are relevant to this talk. You heard we co-direct the UW Neuroscience Institute. And our goal today is actually a really simple goal. We want to just provide an overview of the work of the Neuroscience Institute and where we feel our two departments are at this particular time in history. And I put broad there, I can't emphasize that enough. This is a broad brush stroke sort of overview by necessity, because we'd like to cover a fair amount of ground. Jurgen's introduction took all of our Q&A time, so hopefully we'll be able to finish on time. We'll see how that works out. Let's start with this.
Yeah, next one. What's our history here? Probably one of the most disruptive places in the country for neuroscience and clinical neuroscience. And it starts off with the first chief of neurology. So it wasn't a department, it was part of the Department of Medicine. At age 28, Fred Plum, a neurologist, a brilliant neurologist, finishes his time in the Korean War, and he comes and is recruited by Dr. Williams to Harborview Hospital to become the first neurologist at UW. And he comes to Harborview. Imagine in 1953 what it looks like. There are unconscious patients in every room, okay? And this is 20 years before the CT scanner. This is 35 years before a commercial MRI is available. And his job is to make a bedside exam that will tell us which patients need to go to the OR, which patients need to go to the psychiatrist, which patient has an overdose. Imagine back then, the medication that caused most overdoses were barbiturates. In trauma, there was no CT scanner to know. And he develops the neurologic exam that we use to this very day. He is an amazing man that was into preserving the brain. So next. So he produces from Harborview Hospital, from the University of Washington, a contemporary book at that time called The Diagnosis and Treatment of Stupor and Coma, that is used by medical students from every specialty, from emergency medicine to psychiatry to neurosurgery, neurology, you name it. And he says intervention in minutes can often make the difference between life and death for the patient. The exam is faster and more accurate, and the Glasgow Coma Scale, written by those two neurosurgeons in Glasgow, is based on Fred Plum, a disruptional character. It started here at Harborview, and if you ever have read that book, it's based on the work of seeing unconscious patients at Harborview. Now, another disruptional neurologist, I'm sitting next to my third most disruptional neurologist, but is a guy named Mike Kopis. Mike Kopis was, to me, I worked with Dr. Kopis, and we called him Dr. Kopis, never Michael. He was like Batman, okay? He saw the entire city. He ran the city of Seattle. He, with the chief of cardiology and the fire chief, Gordon Vickery, come up with this idea that we're going to put the emergency room in an ambulance. Okay, it's not going to be a hearse that people drive around the city, which is what it was in the 50s and 60s. They're going to design an ambulance that was a moving emergency room, and they're going to save people on the streets of Seattle. Morley Safer in 1970 says the best place in the country to get a heart attack is Seattle, because you're never 7 minutes away from from Harborview or from an ambulance that will save your lives. To this day, King County is probably the best place in the country to suffer, not that it's a good thing, to suffer a heart attack or stroke because of Mike Kopis, a neurologist who came up with a disruptional idea of putting this ER in the ambulance. He also is the founder of Airlift Northwest, that brings you patients from everywhere in the 5-state WWAMI area.
I must say, I like this picture. You see the bullhorns?
Yes.
This is a Harborview ED. We wanted to also highlight, in addition to some of the sort of founding disruptors in our space, we wanted to highlight the founding chairs of our two departments. Ward, you see on the left there, was the first neurosurgeon at UW. 1961 is when he joined. He was one of the first, if not the first, to be funded by the NIH, a true sort of surgeon scholar, surgeon scientist. And on the right there, you see Bruce Ransom. And Bruce came here from Yale as the chair of the neurology department in 1995. Bruce was quite a character. He is now leading a neuroscience effort at the Chinese University of Hong Kong. He moved to Hong Kong in 2019. I'm the second chair of the Department of Neurology. One comment I did want to make about that, the Magnuson Health Sciences building at UWMC is where we both have offices. We're at Children's right now, in case you're wondering, in Rich's office. It was named after Senator Warren Magnuson, and Bruce was recruited under an endowed chair that is the Magnuson Endowed Chair. And one of the things about Senator Magnuson that I just think is so precious to me, holding the endowed chair now, is that he's the person who started the NIH. And what a dynamic time we're in now in terms of NIH funding, but what an impact the NIH has had on health and disease in the world at large. Why? So that gives you a little bit of a sense of where things started here. We thought we'd talk a little bit next about why this time for neuroscience is so pressing in our minds.
So what's the prevalence and incidence of neurologic problems in the world? Well, and as Jürgen reminded us, I remember his talk, 20% of the world suffers some kind of mood disorder, depression, 300 million people. Well, not counting mental health, if you look at the top 37 diagnoses in neurology and neurosurgery, it is the #1 cause of global burden. Okay, this is from the Institute for Healthcare Metrics that Chris Murray runs at the University of Washington. He looked at the years living with disability, YLDs, the YLLs, years life lost, and disability adjusted life years, one of the most important measures. 43% of the world suffers from some neurologic diagnosis. That's right now at this moment, that's 3.4 billion souls in the world. And what are the 37 conditions? Well, I'll show you a heat map with that. But also worrisome is that these neurologic diseases and conditions have increased almost 20% in the last 20 years, okay? And the 10 conditions that are the most common: stroke, #1 killer in the world neurologic, after heart disease, which is the #1 killer all around. Neonatal problems like hydrocephalus, 1 out of every 770 children are born with hydrocephalus. Migraine, right now 1 billion people in the world have headaches, either tension headache, migraine, or medication-related headache. Dementia, epilepsy, meningitis, diabetes, diabetic neuropathy, CNS cancers, brain tumors, and neurotrauma, of course. All right, and look at this heat map. The red in this heat map shows you all the top diagnoses. And these are not mental health diagnoses, with the exception of one thing. There's autism in the top 10, okay, the autistic. And you're having a speaker next week, so that's timely. But not stroke, #1 killer, #1 cause of morbidity, dementia up there in the top 10, epilepsy, trauma, you name it. And on the x-axis, you can see all the countries affected. Chris Murray looked at every country, 204 countries, okay? And most of them, where the burden is the worst, of course, as you would expect, in low income and middle income countries. That's where the burden is greatest.
So a tremendous burden of disease. Rich and I like to say that every single family has a neurological story. You think about your families. In your nuclear family, in your extended family, there's undoubtedly people that have suffered from these conditions. We also acknowledge how complex neurological health and disease are. And I think our specialty divisions can be a little bit confusing. So we think about things on a spectrum here. And if you imagine macroscopic from the forest to microscopic, like the leaves on an individual tree, neurosurgery is on the macroscopic side, obviously, right? Tumors, aneurysms, fistulas, spinal epidurals, things like that. We think of psychiatry on the microscopic side, neurotransmitters, circuitry, and then neurology somewhere in the middle. And I really appreciated Jürgen's opening comment about how in the future, will there be a neurology and a psychiatry? Because the way that I've always thought about psychiatry is that it's neurology that hasn't been discovered yet. And I don't mean to offend any of you. I hope no one takes that badly. But when you think about it, all these neurological problems are circuits and neurotransmitter related. I mean, Alzheimer's was a psychiatric diagnosis until it was figured out a little bit more about the pathology. And I think we'll see a lot of psychiatric diagnoses moving into an intermediate space, and we'll be able to do things about them that we just can't imagine doing now. Obviously, would highlight rehabilitation, underlying, underpinning, and supporting all of that, and without a doubt, biomedical research, which is necessary for all of these areas. So we're dealing with a complex structure that manages complex neurological health and disease, and we've had some historical challenges to curing brain disease. This is a graphic from Ed Lean that just that highlighted some of the pain points or pressure points as we've tried to work on these diseases. Some of you might remember the decade of the brain with George H.W. Bush, 1990. He signed the paperwork. It's going to be 10 years of incredible progress. There was all this optimism. A little premature, as it turned out. I think the biological complexity was underestimated. This is 2025. This feels like the decade of the brain to us. And that's because we have new tools and new techniques. And so these historical challenges are gradually being overcome. And we wanted to put this picture here just to remind you that in the entire universe, there is no structure that we know as a species that is more complex than our brains. It was the last thing we did in neuroanatomy and neurophysiology right at the end of our anatomy and physiology courses in med school, because it was the most complex. And I think about that sequence when you think about understanding an organ and curing disease in an organ, preventing disease in an organ. The brain is the final frontier. And at the end, we'll talk about why we think this time is going to impact people as much as we do. But it's an incredibly complex organ. And these new tools, these new techniques, whether it's imaging things or tools that allow us to peer into cells, like we're opening the window into cellular function, they're really revolutionizing how we conceive of neurological disease and what we can do about it. And so we have a complex organ with complex disease. We're excited about it. What is the Neuroscience Institute, and what role does it play in affecting the change that we see? I'm going to show you a picture. I showed my wife these slides last night. She said, wow, that's a dorky picture of the two of you. You know, we're bringing dorky energy because we feel really, really strongly about this. And the Neuroscience Institute is an alignment, a partnership that we hope is going to solve local and global neurological conditions. It's the Department of Neurological Surgery and the Department of Neurology. It's focused on aligned strategy. And so we have a goal of growing together in ways that benefit both sides of the equation there. It's obviously focused on funding and margin generating work. And is there ever a more important time than now? A good example there would be our epilepsy program. We have one of the country's busiest epilepsy programs, one of the country's busiest epilepsy surgery programs. And those two pieces need to go together for us to be able to grow and support other aspects of our department's work and the system at large. And then I just highlight that we have a unique administrative structure. We're the only two departments in the School of Medicine that share an administrative structure. Our Vice Chair of Finance and Administration, Janet Pettit, is actually the reason I think that it works as well as it does. I'll give you some numbers here. I'm going to use our colleagues in radiology as an example. So in radiology, for each administrative FTE, there are 9 faculty FTEs that have been supported. In our combined departments, which are similar in size, I would argue at least similar in complexity, possibly much more complex when you think of all the subspecialties, the clinics, OR time, and all of that. We have 1 admin FTE for 22 faculty. And so we've been able to run lean. We think we're a little too lean. Jan is in full agreement with that. But understand that combined structure allows us to align in 100 ways that are not on this slide. So 2 thumbs up in terms of the alignment. And it's a really strong partnership. Neurology and neurosurgery are the 2 components of the Neuroscience Institute, but we interface with multiple other aspects. Your department, obviously in psychiatry, especially on the neurology side, the rehab department for both neurology and neurological surgery, and then we both interact all the time with neuroradiology and neuropathology. At the bottom, we just highlighted neurobiology and biophysics, the new department formed from biological structures and P-bio, as the nucleus in the biomedical research realm. But we work with all sorts of other biomedical research groups, from immunology to bioengineering, right? And so think about the Neurosciences Institute as this entity. We wanted to give you a little sampling of some of the things we deal with. This is a non-complete list, but just so you have a sense. I mean, Rich, you want to point out any areas here?
Just look at the wide spectrum of subspecialization. Anything from Parkinson's disease, which is the second most common cause of degenerative disease in the world after Alzheimer's, dementia. The first neurogenetics division in the world happened at University of Washington in the Department of Neurology. Neuromuscular, and that doesn't include the ALS Center, headaches, neuro-ophthalmology, multiple sclerosis, a world-class multiple sclerosis center, neurotrauma, the busiest neurotrauma center in the country, one of the busiest stroke and cerebrovascular centers in the country, and a world-class neuro-oncology center that involves neurologists who do oncology with neurosurgeons who do tumor surgery. That's just, and of course, Bay has already commented on epilepsy. But that's just a sampling of the wide spectrum. But all 37 conditions, with the exception of autism, that's in psychiatry, are done in the Neurosciences Institute.
I'll say, as someone who came here from outside a few years ago, I was astonished at how many of our practices are the biggest in the country, the best in the country, the first in the country to do something. It's really a remarkable, remarkable landscape. And imagine all these providers, all our faculty, trainees, and staff with one single mission. And our mission is the mission of our institution to improve the health of the public. We take the neurological angle on that. So we're here to improve the neurological health of the public. And that means that we are dealing with clinical care, we're dealing with research, we're dealing with education, and we're dealing with advocacy as aggressively as possible.
As all of you in psychiatry obviously practice in all 5 of our academic centers. I have operated in all 5 of these centers, and we always say the beauty about the University of Washington is the 6 different entities include Airlift Northwest, and then of course the challenge of the University of Washington is 6 separate entities. So we feel your pain.
We also have a very sizable whammy presence in the Department of Neurology. We're the 3rd largest neurology department in the country. In addition to that, we have about 220 affiliate neurology faculty across the whammy. And they are incredible providers, doing amazing work in amazing places. And it's such a pleasure to be able to support the work they do. Rich, what about neurosurgery?
Neurosurgery, yeah, so two points. Neurosurgery, there's one level 1 trauma center serving 5 states, 27% of the landmass, which you all know in the whammy area. For neurotrauma, head, spine, and vascular. But having said that, many of you know, if you're on the curriculum committee, there is a required neurology and neurological surgery. You have to do a required 12-week, month of neurology or neurosurgery as part of your clinical neurosciences at the University of Washington. And that is year after year, one of the, as part of our education mission, one of the most highly rated required rotations at the University of Washington. But the only way we can cover all the medical students for neurology, they have to do it in Alaska, Washington, Montana. They have to offer that clerkship everywhere.
And then, finally, I would say that we're working to raise the profile of neuroscience. If you look at every major health system in the country, neuroscience is a primary focus of this in terms of investment, in terms of growth, in terms of expansion. And that's because it's at this inflection point, that decade of the brain we referenced a minute ago. We're doing our part here at the University of Washington to try and bring up the profile. This was the benefit for Harborview Medical Center this year. Neurosciences was the featured entity. It was an incredibly successful evening, a wonderful event. But it's just one example of the many, many things that we're doing to try and make people think about neurosciences and be excited about it. Having said that, what are we excited about?
Well, what is the future? The 5 advances. People always ask, what are the advances in neurological surgery that have changed the world for us, the way we operate? I mean, half of the operations I now do weren't invented when I was a resident. And half of the operations my faculty do, I can't do because I wasn't trained to do them. So, of course, the advances for whether it's psychiatry, neurology, or neurosurgery, imaging, of course, that's changed the world. But for us, it's using, this morning, I did a brain operation on a baby, on a child rather, excuse me, and I had to use stereotaxis based on the imaging, basically a GPS map to make sure I was in the perfect space, perfect place. Endoscopy, minimally invasive. Everything that we do, we now do minimally invasive brain and spine surgery through an endoscope, through a little hole, instead of maximally invasive. Deep brain stimulation changed the world we live in. Robots, lots of operations we now do are done by robots. And then I'm just going to take a selection of this. I'm going to tell you a little bit about an exciting new brain-computer interface. And then lastly, one of the biggest things that has happened in neurosciences, and I say that because Bay does this. This is what Bay's career was based on, is endovascular intervention for stroke. So this is 5 randomized studies showed that superior to medical treatment is the endovascular treatment of a clot that lays in a medium to large vessel. Lots of strokes are caused by clots sent to the brain in the middle cerebral artery territory or major territory. And in the past, or even currently, the medical treatment was heparin or some anticoagulant of some sort, TPA, for example. Now we can stake a catheter.
Go to the video.
Yeah, sure. Let's just go to the, here's something. This is always amazing to me because this is what happens. So we have carotid and vertebral arteries that go up to our brain, that feed our brain blood, okay? And clot from whether it's the heart or anywhere else in the body lodge there, thus a stroke, okay? Causes ischemia, all right? Now the treatment is so advanced, so complex, and I can say that you see the guide wire going up. The guide wire goes through the clot, snares the clot. Then they send a microcatheter up, okay? Opens up a web. You'll see the web in a second. And that web pushes the clot out of the way and then embeds the clot in itself. Imagine this is all being done within an hour, within hours of the stroke happening, okay? permits blood flow first, and then the neurointerventional, and we have neurosurgeons doing it, neurologists and radiologists doing it, and they're all in one department. They all work together in a very collaborative fashion, one of the few places in the country that does that. And now blood flow is restored. And I know this is so remarkable because my own mother, who had a cardiac operation, 30 minutes after her operation, she stopped talking and stopped moving her right side. The neurointerventionalist went up, pulled the clot out, and I don't think she stopped talking for 5 years after that because it was a life-saving. And you talk about disability. You don't live long with a left-sided stroke. And now millions of people are being saved every year from this operation. Next. Brain-computer interface, and you hear a little bit about that through our dog expert. He built Neuralink, is his company. Well, our company here, 55 years of research at the University of Washington on brain-computer interface. It involves neurologists, neurosurgeons, engineers, computer scientists, and rehab doctors. In fact, Bay's wife is involved in this study, and the study is the goal is to induce cortical stimulation, put these electrodes, you'll see the electrodes to sense the electricity in the brain, and then to stimulate to enhance stroke recovery and rehabilitation. It's one of the things that actually got through NIH, has been approved, and we're now recruiting, first place in the world to recruit for this closed loop stimulation of the brain to rehab the brain after a major stroke. It's very exciting work. And this kind of brain-computer interface work is going to be done around the world to help maybe move a paralyzed arm or leg, just as well as rehab for stroke. Endoscopic approaches. And I want to just show you, it was so crazy. This is a paper I tried to get published back in the 80s. And imagine being a young neurosurgeon, and in the first review I ever got in my life, this is encouraging to any residents that may be, this is the first review I get. This is the single most dangerous surgical approach this editor has ever seen. It should be mentioned in the literature only to be condemned for single-minded insanity it brings to this field. And so I went home and I told my wife, I said, maybe I should be a truck driver. I don't know. Maybe that's what they're telling me. But anyway, I persisted. And sure enough, all these endoscopic techniques, that was a picture of a baby with hydrocephalus and a brain tumor. And this is what it looks like doing it through a hole in the brain. We put an endoscope in. And that tumor that you saw sitting there, there's the tumor. And then to treat the hydrocephalus, what we do is we pop a hole in the bottom of the brain, in the bottom of the third ventricle, and we can drive the endoscope into that. And that releases all that cerebral spinal fluid, and the patient doesn't need a shunt. And there's the basilar artery, the big basilar artery sitting in front of the brainstem pulsating. And we can see this all through a little endoscope. And there's the brain tumor, and we can take a piece of this brain tumor and remove it. So that's the magic that has occurred in the 30 years since I've trained. Now, deep brain stimulation is another. Instead of ablating, instead of destroying brain, we now stimulate brain to treat diseases like Parkinson's disease. We put 2 electrodes in the subthalamic nucleus like this. And what this does is remarkable. We can stimulate the parts of the brain, the dopaminergic parts of the brain, so that people that suffer from Parkinson's, which is a devastating neuro condition, can live life and function. Let me show you those are the 2 implants in the brain, and this is done in a CT scanner. This operation is done in the operating room in a CT scanner. It's minimally invasive. Next. And this is what it looks like with the stimulator off. This is what Parkinson's disease looks like. Look at the shuffling gait, the arms, the masked faces. It's a terrible condition. And sometimes medication doesn't work. But now, with the deep brain stimulation on, he's a normal person.
Look how he pivots on one
He
leg,
can
right?
pivot on one leg, he can walk, he can function. And this is the difference by stimulating, not destroying pieces of the brain. What's the future for psychiatry? And Jurgen and I talk about this over the decades. We've talked about, wouldn't it be great for treatment-resistant depression if we can find targets in the brain, find the electrical circuits that we can stimulate that could overcome some of the medication-resistant depression. Remember, 300 million people in the world, 20% of the US population. So the targets have been the subcallosal cingulate gyrus, lateral habenula, ventral capsule. And our hope is in the future, there are successful trials to do this. You'll see that one of the, this is from Houston, from Samir Seth. Basically, what they're trying to do is record from areas of the brain that may be involved in depression, and then use brain stimulation to stimulate those areas for drug-resistant depression. That's the future. It's done successfully in a small number of patients now, but we'd love to be able to say that we can find targets to stimulate in the future.
And it sort of goes back to the comment about neurotransmitters and circuits. You know, it's all about circuitry and what's talking to what, and stimulation allows interruption or an enhancement of those sort of circuits.
Yes.
So some neurosurgical things you're interested in. I'm going to share 3 things that I'm interested in on the neurology side. First, locally, to our work here in the WAMI area in Seattle, innovations and access. And I know that this is something that neurology and psychiatry share very closely. We have wait lists that go back months. We were talking about patients this morning in the clinical chairs meeting, and commercial versus non-commercial patient insurances. And I was thinking, you know, we could just say we're only going to see commercial patients for the next 3 months, and we'd still have a wait list that goes on for months. We have just a tremendous volume of patients. And so we're trying to be innovative in the way that we deliver care. In this picture here on the left, you see a Project Echo for dementia team. We have a Project Echo in dementia, Project Echo in MS. These folks are dealing with 64 different sites across the state. It's a highly successful Project Echo model to try and get expertise out into the community. In this middle picture, you see a picture of our new telestroke and teleneurology platform. We went to iPads and Zoom. Keep it simple, keep it cheap, make it user-friendly, allows it to disseminate far more broadly. And this has been a very successful transition. And so these are moving a provider virtually. And I know you in psychiatry are very familiar with these techniques. Then, of course, we also move providers physically. These are 2 of our pediatric neurologists holding a specialty clinic. I think they're in Bethel or Sitka. It looks like Bethel in Alaska. And we have providers that are going out through the WAMI and holding specialty clinics that are batched, so patients collect and have a neuro-ophthalmology clinic, say, once every 2 months, or whatever the subspecialty area is. These are just 3 of multiple facets. Some other things that we're considering is the role of primary care. We have ongoing sessions with primary care colleagues for headache, which can often be managed in the primary care setting, even with fairly advanced therapies. For diagnosis of cognitive impairment. Again, often something that can happen in the primary care setting. So when you come up to the university level, you're going on to the next step, which is therapeutic options. How do we leverage e-consults? If any of you have tried to consult neurology, you'll see that pop up that says, is this appropriate for an e-consult? We've tripled our e-consult volume by doing that. And only about 1 or 2% of all of our e-consults end up converting into clinic visits. So from our perspective, that's providing an awful lot of neurology input to a whole lot of providers and their patients without adding to the wait list, which is already so burdensome. And then I'm sure you already have this model in multiple parts, but we're thinking about consult-only outpatient care. A good example is autonomics. We're the only group in the Pacific Northwest that treats autonomic disorders, so POTS and neurogenic orthostatic hypertension and things like that, diabetic neuropathy and some of the autonomic issues with that. That's the longest wait list we have. It's almost a 9-month wait list. And so if we consult and then send a patient back to their provider, whether it's the cardiologist or their PCP, with a plan, does that allow us to get more patients seen, but still not compromise the quality of overall care? And we're working through that actively right now. So innovations and access is the first thing I'd say is exciting. I don't know if that exciting captures access, but this is critically important work. The other thing that is really thrilling is what we're seeing with disease-modifying therapy. I'm going to use the example of Alzheimer's disease. As Rich said, it's the commonest neurodegenerative disease in the world. We've seen some big developments here, but know that this is happening across all our subspecialty areas. I mean, when I did med school, if you had MS, you were in a wheelchair in a decade. When I was in residency, it was about 15 years you'd be wheelchair bound. Now, MS is almost a chronic disease. The people that you pass every day, the people you might be working with that have MS, because the medications to treat it have come so far. So using the example here of dementia and Alzheimer's disease, we have new therapy that is a monoclonal antibody that pulls amyloid protein out of the brain. The first drug approved was called lecanemab. There's an additional agent now called donanemab, approved just brought into our practice just a week and a half ago. This is the first patient in our practice to get lecanemab. This is December of 2023. I think he was the third or the fourth person in the country, certainly the first on the West Coast, to get this drug infused. Mike Rosenblum here in the gray jacket is the neurologist who helped set the whole program up. And you can imagine it's a really big change from a typical clinic visit for dementia where you're doing symptomatic management. Because now you have to image these folks and assess if they're candidates. You have to have specialty pharmacy access, infusion therapy access, LPs. I mean, there's a whole range of things now that were not part of the paradigm before. And we spent 8 months making those changes in preparation for FDA approval. This is a medication that slows your decline from Alzheimer's disease by about 30%. And you may have heard some conversation about that. You know, is that such a big deal? Is it worth it? Is it? I personally am just stunned by that. This is the first disease-modifying treatment for the worst form of dementia we have on the planet. 70% of non-vascular dementia is Alzheimer's disease. And I think about it like a foot in the door. I was talking to Rich about HIV. Think about AZT, very toxic when it first came out. It was very expensive, but there was something. And based on that, you could build on it DDC and then heart and then all these other things that turn HIV into a chronic disease. This is the foot in the door for Alzheimer's dementia. And so we have a large program that's continuing to expand. We're building more infusion capacity. And there's a trial right now looking at giving this medication before patients are symptomatic. The disease, the protein deposition starts around my age, late 40s, early 50s. The disease manifests mid-60s, mid-70s, right? What if we started attacking it then? What does that imply for you later? So very exciting. I put here functional goals are achievable in the short term, the cures are farther away. And using dementia as an example, I'll just point out, if we could push the onset of your dementia by just 5 years, we would halve the incidence of Alzheimer's disease, because it's an exponential increase with age. 1 in 3 people over the age of 80 has Alzheimer's disease. So there's an exponential increase. And so even those small gains can have a very, very sizable impact on societal burden of disease. And then finally, the rise of brain health. You know, Jürgen mentioned a brain health department. This is a concept that is relatively new. There's the definition there from the American Academy of Neurology. I point out optimal neurological function. In the absence or presence of disease, how do we optimize your function? And where I think we've really made a massive step is this idea of conceiving of it through your entire lifespan. This is a single line drawing of a human life from fetal life to senescence. You know, think about fetal life. What impacts on the mother, for example, affect the way the fetus is developing? You might have seen some of the recent questions related to Tylenol and ADHD. How do you protect teens? Social media, all the cell phone use. Think about the brain as the organ we're trying to keep healthy there. And so we're going to see more and more of this brain health paradigm, more and more work being done to understand what does brain health look like, how do we support it best, and how do we stave off some of the diseases that our population has suffered. So those are three things from the neurology side that I'm excited about. I'd say that Rich and I are really excited about the idea of UW Neuroscience. Rich has been here for many years. He's been pushing for this as an entity for many years. I think we finally have some traction here. And the idea is going to be that we have one umbrella that everything neuroscience related comes up under. We talked about the Neuroscience Institute and all of our partners there. Think about the School of Engineering, computer science, and all of that. Think about bioethics. And think about all the other areas of this university that deal with neuroscience, from nursing and pharmacy to our biomedical research colleagues, right? So imagine an umbrella that goes over all of that. I also put a plug in here about the Washington Initiative for Neuroscience, which is the state view of this. We would be a nested entity within a statewide enterprise. And Jürgen is part of the initiative now. We're trying to get funding. If this funding happens, then you'll hear a lot more about this as we go forward. The Wild Neuro Hub, Jürgen was the first physician representative on the Wild Neuro Hub. This gentleman in the gray jacket is Tom Daniel. This is Sandy and Joan Weil. They are the benefactors. Weil, same Weil as Weill Cornell. They gave 130 million to projects that are run with UCSF, UC Berkeley, and UW. And so those three gentlemen in the background are the representatives of those three institutions. And research in the neurosciences that involves those three sites is funded through the Wild Neuro Hub. So an incredible funding opportunity for our faculty because the competition pool is as tight as it is. I was the chair that followed Jürgen, and I just rotated off, and Rich is actually the chair now. And so we're very excited about this as a philanthropic opportunity. And we just highlight the potential of philanthropy in general if we're presenting a unified front to other institutions or to other donors. There's also collaborative funding. This is the Washington Research Foundation that supported clinician scientists effort. And this money came through the Neuroscience Institute, but in our minds, we want to support neuroscience, right? And so what you see in the awardees, Sam Emerson's a neurosurgeon, Eula Goost is a neurologist, Rebecca Hendrickson, I don't know if Rebecca's on or not, she's a psychiatrist, obviously, and then Monica Sanchez-Contreras from DLMP. So we want the whole spectrum represented. And there'll be many opportunities like this as we go forward. And then finally, shared training opportunities. Multiple shared training opportunities. The one that we've chosen to highlight here is the new Behavioral Neurology and Neuropsychiatry Fellowship. This was started by Michael Schrift and Michael Personer, the Mike Squared. And what you see here are our first two fellows. And this is a fellowship that nationally has about a 30-35% vacancy rate. And we debated that starting this up, but we have such a rich psychiatry and neurology interface with cognitive disease. Our first two fellows were fantastic. Kalania Jimenez and Sung Ji. Sung is going to be staying on faculty in the neurology department. Kalania is a psychiatrist, sorry. Our next two fellows are going to be two of the three chiefs from the neurology department this year. And that's the kind of momentum that we're excited to see. And so thinking about where we can share training opportunities is of great interest to us. So that gives you a little bit of a broad overview, some things we're excited about, and a little bit of the history of our Neuroscience Institute. I'm going to ask maybe you, Rich, to give us some closing thoughts.
So I think I'm going to close with the manner in which our partner, Jürgen Unitzer, started. There's collaborative opportunities here. I think neurology, neurological surgery, psychiatry, we're all interested in the same thing, circuitry of the brain. At the cellular level, what are the cells doing in the brain? And there are engineering solutions, there are practical solutions to access. You're talking about the #1 cause of disability adjusted life years in the world. And so I think there's beautiful beautiful opportunity for us to continue collaboration for all of us that are interested in circuitry of the brain.
Nicely said. And I would just comment that our excitement about the current state of neuroscience and the potential that we see ahead is that we really feel like this is something that is going to be transformative for human health. If we understand our brains, if we can protect our brains, if we can optimize our brains, whether it's memory function or sleep or the way that we age cognitively or the burden of mental health that we deal with, addiction, right? If we can deal with those aspects of our human experience, what does that do to our destiny as a species, to our capability as a species? And so we're so thrilled that we get to lead the Neuroscience Institute at this particular time and to share that experience with all of you. So we'll end with this slide and a great big thank you to Jürgen, to the Psychiatry Department for this invitation and for the chance to be your friends and collaborators. Thank you.
Well, thanks to both of you for a really amazing, inspiring conversation and presentation today. In the short run, I think we're all living in some disturbing, scary times, but this kind of presentation gives me hope for the future, and I just want to thank you for that. Jed, I don't know if you want to pop back on here.
I'll pop back on here. Yeah, thank you both so much. I can't speak for everybody else on this meeting today, but if you had only shown me that video of how you retrieve a blood clot from the brain, then I would have considered this an incredibly educational day. So thank you both. I really enjoyed it. We do have time. We have about 3 or 4 minutes for questions. I don't know if anybody online is typing a question right now, but if you have anything, please go ahead and type it into the Q&A. Maybe in the meantime, while we wait, I kind of like this. We have the both of you in the same room there together. We have this kind of tag team mini panel discussion. Do either of you have questions for each other that you would like to ask? A little more follow up on something that we heard earlier?
I might ask Rich what he feels has been the driver of our progress in terms of the neuroscience entity at UW Medicine.
I'll be honest, it goes again to the collaboration. I love the neurologists at the University of Washington have been disruptive in their professions. And your addition here has been such a breath of fresh air for us to work together. So to give you an example, you love that stroke video. We're one of the only places in the country that has neurologists, radiologists, and neurosurgeons all in one department, not compete. Guess what? They don't compete for each other. It's a high margin procedure. It's highly dangerous, obviously, and saves millions of lives. But here, we all work together and not compete for these patients. And we supply what I would say one of the best products in the country in terms of saving people's lives. So that's sort of what's so beautiful about the collaboration that exists between the 3 chairs on this.
Yeah, and what I would add as an invitation and challenge to my colleagues in psychiatry and behavioral sciences is, thinking about what you heard today, and I can't help but thinking we're inspired by this. Think about what it is that we could bring to a collaboration in this area. We've gotten a pretty big investment over the last year in building an interventional suite for neuromodulation treatments. We have a very limited number of, FDA-approved treatments now using transcranial magnetic stimulation for things like OCD, for things like depression, but we have almost unlimited potential for thinking about brain stimulation, for a whole range of psychiatric and neurological conditions. What about chronic pain? Another huge driver of, challenges that come to a physician's office, a huge driver of disability. So let's try to be inspired. Let's try to be creative. Let's think about what it is that we could bring to a collaboration if we wanted to do that in the future.
Jürgen, do you think let me ask you, you and I have kind of dabbled in this. We've tried to get faculty interested. Our faculty is now interested again in the thought of treatment-resistant depression, TRD. Do you think that that's a legitimate thing that people are thinking about, trying to map circuits and stimulate certain areas of the brain? I mean, some of the studies are pretty impressive, but should we be doing that here?
Yeah, we should. I think some of the early research it sort of had mixed findings. I think,
Yep.
as with any technology, there is a timing issue. When do you know enough? When is the time right to do it? I think some of the early trials in treatment-resistant depression had sort of mixed findings. But I think you learn from all of these things. And I think, yes, we should absolutely be thinking about how do we collaborate on that. And I think we have recruited a fabulous colleague from UCLA who runs our neuromodulation program up at Northwest Hospital, Dr. Espinoza. We have other colleagues like Dr. Schrift and others who I think could bring a lot to a collaboration in this area. So absolutely, this would be a great time to think about that again.
And is there any role for focused ultrasound in psychiatry?
There probably is. There are people who are working on that. We don't have anybody in our department right now who's working on that, but there are others who are exploring that as an intervention modality. So absolutely. Yeah.
All right, well, that brings us to time, so I'll go ahead and wrap us up here. So thank you both for being here. I know you're very busy, very, very in demand, so we appreciate your time. What an inspirational talk that was. We do have people typing in their thank yous in the comments there, so appreciate it. Folks at home, thanks for joining us. Hopefully you can join us again next Friday, same time. Until then, have a good weekend, everybody.
Thank you.
Bye.
Thank you both.